everyone, my name is Onisha Hudson and I'm a proud student of the QualiTest Training Institute. Today I'm compiling my phlebotomy video for my final project. This will basically be a compilation of what is phlebotomy, what phlebotomy is all about, what it consists of, and many more. Some of you might want to know what exactly is phlebotomy. Phlebotomy is an incision into the vein for the purpose of drawing blood. It is primarily accomplished by one or two procedures. These are the venipuncture and the capillary puncture. Procedure 1, venipuncture. This includes collection of blood by penetrating the vein with the use of a needle, syringe, and any other collection apparatus. Procedure 2, capillary puncture. This includes penetrating the skin to collect blood with the use of a lancet. What are some functions of a phlebotomist? What are we responsible for? What do we do? Phlebotomists are responsible for preparing patients for collection procedures associated with laboratory samples, collecting routine skin puncture and venous specimen for testing as required, preparing specimen for transport to ensure stability of sample, maintaining patient confidentiality, performing quality control checks while carrying out clerical, clinical, and technical duties, transporting specimen to the laboratory, complying with all procedures instituted, collecting and performing point-of-care testing, POCT, performing quality control checks on POCT instruments, performing skin tests, preparing and processing specimens, collecting urine drug screening specimen, performing electrocardiography, performing front office duties, current procedural terminology coding, and paperwork. Now we move forward with sites for venipuncture. The antecubital area or fossa of the arm is usually the first choice of routine venipuncture. This area is located at the upper extremities and contains the three vessels primarily used by the phlebotomist to obtain venous blood specimens. These are the medium cubital, the cephalic, and the basilic veins. The vein should be visible or palpable after tourniquet placement. The medium cubital vein, most commonly used for venipuncture, lies over the cubital fossa and serves as an anastomosis, which is a connection made surgically between adjacent blood vessels. between the cephalic and basilic veins. We're continuing on the topic needles. Here we will be speaking about needle gauges, needle type, and typical use of these needles. We'll start with the 15 to 17 gauge needle, which is a special needle attached to collection bag, collection of donor units, autologous blood donation, and therapeutic phlebotomy. The 18 gauge needle, which is also the hypodermic needle, used primarily as a transfer needle rather than for blood collection. Safety issues have diminished use. Next, we'll have the 20 gauge needle, which is a multi-sample hypodermic needle, sometimes used when large volumes tubes are collected or large volume syringes are used on patients with normal sized veins. Next, the 21 gauge needle, which is the commonly used needle for patients. This is a multi-sample hypodermic needle as well. Consider the standard venipuncture needle for routine venipuncture in patients with normal veins or for syringe blood culture collection. Next, the 22 gauge needle, which is also a multi-sample hypodermic needle, used on older children and adults, patients with very small veins, or for syringe draws on difficult veins. Last but not least, the 23 gauge needle, which is known as the butterfly, used on veins of infants and children and on difficult or hand veins of adults. Have you ever thought about how phlebotomists actually collect blood? Have you ever seen anything like these before? Well, we will now speak about the two systems in which we use to collect blood samples. System number 1, the evacuated tube system. This is the most common and efficient system preferred by the CLSI for collecting blood samples. This is a closed system in which the patient's blood flows through a needle inserted into a vein and then directly into a collection tube without being exposed to the air or outside contamination. This system allows numerous tubes to be collected with a single venipuncture. For example, using the red top by order pro and then the lavender top. Here is an up-close view of the components of the evacuated tube system. So we have a multi-sample needle here attached to the tube holder, and we have an evacuated tube, which is the red stopper, and we have the lavender. So in taking blood, withdrawing blood, we use the red tube first by order of draw, and then we use the lavender tube. Let's continue with the syringe system. Although the evacuated tube system is the preferred method of blood collection, a syringe system is sometimes used for patients with small or difficult veins. This system consists of a sterile needle called a hypodermic needle, a sterile plastic syringe with a luer lock tip, a special tip that allows the needle to attach more securely than a slip tip, and a syringe transfer device. Let's talk about stopper color, additive and functions and departments. Let's talk about evacuated tubes. First, we have the light blue color stopper. These have the sodium citrate. This is used to prevent donated blood from clotting in storage and can be found in the coagulation department. Next, we have the red stopper tubes. These have no additives, and these can be found in the chemistry, blood bank, serology, and immunology department. Moving along with another red tube, but this one has the clot activator, promotes blood clotting. The glass or silica particles found in the chemistry department. Third, red stopper tubes, but this is also light gray. These have no additives and discard tubes only for department. Our last red stopper tube. This can be red and black tiger, gold, or red gold. Clot activator and gel separator promote blood clotting. Gel separates serum from cells and can be found in the chemistry department. We have the green-gray or light green color stopper that contains lithium heparin and gel separator, found in the chemistry department. We have the dark green that contains lithium heparin, sodium heparin, ammonium heparin, and can also be found in the chemistry department. Moving along with the lavender purple color stopper. This contains EDTA and can be found in the hematology department. We have the gray stopper, and this contains sodium fluoride and potassium oxalate, found in the chemistry department. We'll conclude with the yellow stopper that contains the sodium polyethanol sulfonate, SPS. This can be found in the microbiology department. There's also the yellow stopper that contains the acid citrate dextrose, the ACD. These can be found in the blood bank or the immunohematology department. How are we feeling about phlebotomy right now? Let's continue with the order of draw and rationale. We'll start with blood culture, which is the sterile collections. This is the yellow SPS, sterile media bottles. Minimizes chance of microbial contamination. Next, we have the coagulation tubes. These are light blue. The first additive tube in the order of draw because all the other additive tubes affect coagulation tests. Next, we have the glass non-additive tubes. These are red. This prevents contamination by additives in other tubes. We move on with plastic clot activator tubes. These are also red. Filled after coagulation tests because silica particles activates clotting and affect coagulation. Moving on, we have another tube that is filled after coagulation. This is a serum separating tube, the SSTs. These are red and gray rubber and gold plastic. Carryover of silica into subsequent tubes can be overridden by anticoagulant in them. Next, we have the plasma separator tubes, the PSTs. Heparin tubes. These are green and gray rubber, light green plastic, and green. Heparin affects coagulation tests and interferes in collection of serum specimen. It causes the least interference in tests other than coagulation tests. Let's move on to my personal favorite, the EDTA tubes. These are lavender, pink, or purple. These are responsible for more carryover problems than any other additives. Elevates sodium and potassium levels, chelates and decreases calcium and iron levels, elevates PT and PTT results. Last, but definitely not least, the oxalate fluoride tubes, and these are gray. Sodium fluoride and potassium oxalate affect sodium and potassium levels respectively. Filled after hematology tubes because oxalate damages cell membranes and causes abnormal RBC morphology. Oxalate interferes in enzyme reactions. So, we've concluded the order of draw for venipuncture. The order of draw for collecting multiple specimens by capillary puncture is not the same as for venipuncture. Puncturing the skin releases tissue thromboplastin, which activates the coagulation process in the blood drops. Specimens must be collected quickly to minimize the effects of platelet clumping and microclot formation, and to ensure that an adequate amount of specimen is collected before the site stops bleeding. Hematology specimens are collected first because they are most affected by the clotting process. Serum specimens are collected last because they are supposed to clot. The order of draw recommended by CLSI: is as follows. Number 1, lavender EDTA micro collection tube. Number 2, plasma additive micro collection tubes. And number 3, serum micro collection tubes, example red, no additive. We're going to be talking about the phlebotomy tray. Now, I have a little setup here. It's not exactly a phlebotomy tray, but these are the components that can be found in a phlebotomy tray. So a phlebotomy tray can be used when the patient can't come directly into the laboratory, the patient is in a ward, and the phlebotomist needs to go to the patient instead of the patient coming to the phlebotomist. So here are some of the items or the content of the phlebotomy tray. So we have our gauze pads here. We have like these. We also have the sterile gauze pad here as well. We have lancets as well. These are found in the phlebotomy tray. Enough for multiple takes of blood as well. We have our evacuated tubes. We make sure that we have enough of these as well when we are sucking our tray. We have our hand sanitizer, of course, our latex gloves. We also have, for individuals or phlebotomists that are allergic to latex. We have our cotton balls. Of course, we have our sharps container, our biohazard bag. We have our slides here, and a little makeshift box. And we have our disinfectant wipes. Handheld phlebotomy equipment trays come in a variety of styles and sizes, designed to be easily carried by the phlebotomist and to contain enough equipment for numerous blood draws. They are convenient for stat or emergency situations or when relatively few patients need blood work. It also contains needle and sharp disposal containers, biohazard bags, tourniquet, and needles. Guys, as a phlebotomist, there are 2 things that you should never enter the laboratory without: a watch and a pen. Like doctors or nurses, phlebotomists are also responsible for carrying out a few procedures. Let's start with routine ETS, which is carrying out venipuncture with the use of the evacuated tube system. Let's go through these by steps. 1. Review and accession test request. Review for completeness, date, time of collection, status, and priority. Accession records request and assigned unique number to identify specimen related processes and paperwork. 2. Approach, identify, and match ID band. Prepare patient, explain procedure, and address inquiries. 3. Verify diet restrictions and latex sensitivity. 4. Sanitize hands and put on gloves. 5. Position patient downward in a straight line from shoulder to wrist. Apply tourniquet. Ask patient to make a fist. 6. Select vein. Medium cubital, cephalic, if no other vein is shown, basilic. Release tourniquet. Ask patient to open fist. Clean with antiseptic and air dry. Prepare equipment, attach needle to ETS holder, uncap the needle. Place aside, put the first tube in the holder, according to the order of draw. Reapply tourniquet, uncap and inspect the needle. Discard if flawed. Number 10. Ask patient to remove a fist. To remake a fist, Warn the patient. Anchor vein by holding the arm. Grasp flanges of holder with middle and index fingers. Push tube with thumb. Release tourniquet as soon as blood begins to flow, no more than 1 minute. Fill additive tube until vacuum is exhausted. Mix immediately. 3 to 8 inversions. Follow order of draw. Number 13. Place gauze, remove needle and apply pressure. Recap needle. 14. Discard collection unit. 15. Label tubes. Observe special handling instructions, for example, crushed ice for ammonia, protect from light from bilirubin. 17. Check patient arm and apply bandage. Dispose of used and contaminated materials. Number 19. Thank patient, remove gloves. Number 20. Transport specimen to the lab. Venipuncture of a hand vein, butterfly, and ETS holder. Procedures 1 through 4 are the same for the routine ETS. Procedure 5. Position and support hand on hand rest or bed. Have patient bend fingers or make fist. Apply tourniquet. Proximal to wrist bone. Ask patient to close hand or clench fist. Number 6. Select vein that can be easily anchored and won't bounce. Relax tourniquet. Ask patient to relax hand. Number 7. Clean and air dry site. Number 8. Prepare equipment and put on gloves. Attach butterfly to ETS holder. Grab. Position the first tube in the holder or wait until after needle entry. Number 9. Reapply tourniquet. Hold the winged portion of the butterfly between your thumb and index finger. Cradle the tubing and holder in dominant hand. Uncap and inspect needle. Number 10. Anchor the vein. Insert the needle at 10 degrees or less. You should see a flash of blood. Seat the needle within the vein. Number 11. Establish blood flow and release tourniquet. Place tube in the holder and push part way with a clockwise twist. Grasp holder flanges with middle and index fingers, pulling back slightly to keep holder from moving. Push the tube onto the needle with your thumb. Number 12. Keep tube holder below sight. Fill tubes from bottom up, filling additive tubes until the vacuum is exhausted. Mix immediately, 3 to 8 inversions. Follow order of draw to prevent additive carryover. Coagulation. Draw a discard tube first to remove air in the tubing and assure proper filling of coagulation tube. 13. Place gauze, remove needle, activate safety device and apply pressure. 14. Discard collection unit into sharps container. Needle and syringe venipuncture. Steps 1 to 7, same as routine ETS venipuncture. 8. Prepare equipment and put on gloves. 9. Reapply tourniquet, uncap and inspect needle. 10. Ask patient to make a fist, anchor vein and insert needle. 11. Establish blood flow, release tourniquet, ask patient to open fist. 12. Fill syringe. 13. Discard collection unit. 14. Discard collection unit into sharps container. 15. Discard collection unit into sharps container. 16. Reapply tourniquet, uncap and inspect needle. 17. Ask patient to make a fist, anchor vein and insert needle. 18. Establish blood flow, release tourniquet, ask patient to open fist. 20. Fill syringe. Place gauze with drawn needle, active safety device, apply pressure. 14. Discard needle. Fill tubes, discard syringe and transfer device. Steps 15 through 20, same as routine ETS venipuncture. Let's talk about pediatric venipuncture. Dealing with the parents or guardian. If parents or guardians are present, it is important for the phlebotomist to earn their trust before attempting to draw blood. Dealing with the child. With older children, it is important, as with adults, to gain their trust. Approach them slowly and determine their degree of anxiety or fear before handling equipment or touching their arm to look for a vein. Physically lower yourself to the patient's level. Explain what you are going to do in terms that the child can understand and answer questions honestly. Note well, never tell a child it won't hurt. Instead, say that it may hurt just a little bit, but it will be over quickly. Help the child to understand the importance of staying still. Give the child a job to do, such as holding the gauze or adhesive bandage. Offer a reward for being brave. Pain interventions. Interventions to ease pain include the use of eutectic, easily melted mixture of local anesthetic, EMLA, for newborns, and oral sucrose and pacifiers for infants and toddlers. Selecting a method of restraint. Immobilizing of patients is a critical aspect in obtaining an adequate specimen from infants and children while ensuring their safety. A young infant or an infant can be wrapped in a blanket, but physical restraint is often required for older infants, toddlers, and young children. Toddlers are most easily restrained by having them sit upright on a parent's lap. The arm to be used for venipuncture is extended to the front and downward. The parent places an arm around the toddler and over the arm that is not being used. The other arm supports the venipuncture arm from behind, at the bend of the elbow. This helps steady the child's arm and prevent the child from twisting the arm during draw. If the child is laying down, the parent or other phlebotomist typically leans over the child from the opposite side of the bed. One arm reaches around and holds the venipuncture arm from behind. The other reaches across the child's body, holding the child's other arm secure against his or her torso. Equipment selection. Venipuncture of an antecubical vein is most easily accomplished using a 23-gauge butterfly needle attached to an evacuated tube holder or syringe. The tubing of the butterfly allows flexibility if the child struggles or twists during the draw. Procedures. Regardless of the collection method, every attempt should be made to collect the minimum amount of blood required for testing because of the small blood volume of the patient. Routine capillary puncture. Review and accession the test request. Approach, identify, and prepare patient. Verify diet restrictions and latex sensitivity. Sanitize hands. Position the patient. Select puncture site. Warm the site if needed. Clean and air dry the site. Prepare equipment. Grasp finger or heel firmly. Position lancet, puncture site, and discard lancet. Lower finger or heel and apply gentle pressure until a blood drop forms. Wipe away the first blood drop. Fill and mix the tubes containers in order of draw. Place gauze, elevate sites, and apply pressure. Label specimens and observe special handling instructions. Check the site and apply bandage. No bandage to an infant or toddler. Dispose of used and contaminated materials. Thank patient, parent, or guardian Remove and discard gloves and sanitize hands. Transport specimen to the lab promptly. Now we'll talk about some possible problem sites in phlebotomy. Number 1, obesity. This is the abnormal excessive fat accumulation that presents a risk to health. Number 2, mastectomy, a surgical operation to remove a breast. Number 3, hematoma. This is a solid swelling of clotted blood within the tissues. Number 4, edema, swelling caused by excess fluid trapped in your body's tissue. We have damaged veins as well. And last but not least, burns, scars, and tattoos. Possible patient complications and conditions. Number 1, allergies to equipment and supplies. For example, adhesive allergy, antiseptic allergy, and latex allergy. Number 2, excessive bleeding. Number 3, fainting. 4, nausea and vomiting. 5, pain. 6, seizures and convulsions. Some patients may be suffering from trypanophobia. This is the fear of medical procedures or hypodermic needles. Others may be hemophobic, which is the fear of blood. Here are some steps to follow if a patient starts to faint during a venipuncture. Release the tourniquet and remove and discard the needles as quickly as possible. Apply pressure to the site while having the patient lower the head and breathe deeply. Talk to the patient. Physically support the patient. Ask permission and explain what you are doing if it is necessary to loosen a tight collar or tie. Apply a cold compress or wet washcloth to forehead and back of the neck. Have someone stay with the patient until recovery is complete. Call first aid personnel if the patient does not respond. Document the incident according to the facility protocol. This brings me to the end of my phlebotomy video presentation. Special thanks to Ms. Eva Irving for the opportunity to create my very first YouTube video. It was a lot of work, but it was very exciting. Thanks to the staff of NBTS for welcoming, accommodating, and allowing me to film in the lab. Thanks to Mark Jr. and Nadia Hudson for helping me with the days and nights of filming, trial and error. Special thanks to Annalisa McCoy for being my patient. And a very special thank you to my amazingly brave daughter, Kaya Mentor, for stepping in as my pediatric patient. I love you so much, sweetheart.